Morena, and welcome to the Beginner's Guide to ACC for Allied Health Providers. We will begin with the karakia. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha, mo te o rangatangata, kia puta ki te whai au, ki te ao marama, homie, huie, tai kie. Kia ora koutou. I am Kate Holmes and I'm an Engagement and Performance Manager for ACC based in Christchurch. I'll hand over now to the rest of the team to introduce themselves. So over to you, Nigel.
Kia ora koutou. My name is Nigel Gardner. I'm one of the clinical advisors and clinical services in ACC. My background is in physiotherapy. I'm going to hand over to Kay.
Morning, everybody, and thanks, Nigel. My name's Kay Conifray. I'm a portfolio advisor working in the Allied Health team. I'm based up in Auckland, and I'll hand to Ben, my colleague.
Morning, everyone. Ben Pennicott here in the Allied Health space as well, and based in Tauranga. I'm going to pass over to Mary Hyam.
Kia ora, everybody. I'm Mary Hyam. I'm an Engagement and Performance Manager based here in Tauranga.
Thanks,
and
guys.
I will pass back to Kate.
Yeah, thanks, Mary. So Nigel and myself, we will be presenting, and Kay, Ben and Mary will be moderating the questions. I wanted to start by saying a big thank you for taking time out of your busy clinical days to spend it with us, and we really appreciate it, and I hope you get some good information from it. So this is a brand new webinar format we've developed as part of our new resources for providers. So we'd really like to get your feedback. The link is going in the chat now, thanks to Ben, and we'll repost it again at the end. So this is a 101 to ACC. So a high-level overview covering basics as a part of a foundation, and then we plan to delve deeper into different topics in our future webinars. Please do stay on mute for this webinar as we do have a big crowd today. Questions that have been asked in the registration will be answered at the relevant section, and we'll try to cover questions in the chat too. So just a reminder that this webinar is being recorded to go up on our website, and you'll get the slide deck sent to you with all the relevant links. So don't feel like you've got to frantically jot everything down. So this is our agenda. We'll start by talking a bit about ACC. Nigel will talk about cover and causation. We'll look at regulations versus contracts, registering as a provider, lodging claims, clinical records, our digital services, and finishing with our resources. About ACC. So what is ACC? As you'll be aware, healthcare does look different in New Zealand compared with other countries. As when someone gets injured as a result of an accident, they come to ACC for support. It is important to note that it is no fault cover, and ACC provides the same access to treatment for all New Zealanders and our visitors. What do we do? Well, in summary, we try to prevent injuries, we provide rehabilitation, and we provide financial support to people who are injured in accidents. To do this, we partner with providers like yourself to help get our clients back to independence. How are we funded? Well, we all pay for each other to keep the ACC scheme running. So we are funded by levies from motorists, workers, and businesses. We're also partly government funded for our non-earners and visitors. Now, looking at cover and causation, I'll hand over to Nigel.
Thanks, Kate. So, what is cover? It really means whether a claim is accepted or not. It's only once cover is approved for an injury that ACC can consider funding assistance for that injury, such as treatment and other supports like weekly compensation, that sort of thing. I like to use the example of motor vehicle insurance. If you have a ding or a fender bender, call up the insurance company, and depending on your policy, in ACC's case, this is the legislation, the claim is either accepted, so you've got a comprehensive policy, or not. say you have maybe third party only. Cover's the same really on a fundamental basis as an insurer accepting a claim. So what can ACC cover? Well, we cover what's called personal injuries. And this includes both physical injuries, mental injuries caused by physical injuries, mental injuries caused by certain criminal acts, or mental injuries caused by traumatic work events. Now, for the purpose of this talk, I'm going to focus more on physical injuries. That's my background as a physiotherapy, that's what I'm more familiar with. But the same principles will apply whether it's a physical or a mental injury. And I'll just add that ACC is doing separate webinars on mental injuries that will be on our website if you're interested in more detail on that. So we can't cover some things. Okay, so we can't cover things really that aren't physical injuries caused, or that are not caused by a qualifying event. So it's almost the opposite of what I said in the previous screen. So a qualifying event, so as I mentioned, a specific accident or injuries caused by other conditions such as a treatment injury, they're coverable. Things that aren't caused by that. Something like maybe septic arthritis from an unknown source will typically not be covered. Or gradual wear and tear from aging or other degenerative processes are also not covered. So what's an accident? So like I said, I'm primarily going to talk about physical injuries caused by accidents. An accident is sort of in an everyday sense, it's relatively obvious, an unexpected incident or a sort of an unintended event. But in ACC terms, it's maybe a bit wider than that. It doesn't necessarily mean things that aren't unintended or unexpected. It's been defined in the legislation as meaning it's sort of any external force on the body or application of an external force, say in response to the ground, gravity, a twisting movement, pivoting, those sorts of things. It's sort of any sort of force that's not a force that's internal to the body, and something that's, for example, of that is maybe biting your own tongue. Now that's an internal force that's not covered by us. Now, for the ACC purposes, a series of events over a defined period of time also constitutes an accident. This usually relates to an unusual activity for that particular person, doing something that they're unaccustomed to. Developing an injury in relation to that. An example of that might be someone who's normally pretty sedentary, goes on a 3-day hike, and they might develop a massive blister on their heel. Now that could be an accidental injury, at least in ACC terms. So that obviously begs the question, what is an injury? Well, in its simplest form, an injury is a physical harm or damage. And like I say, I'm talking more about physical injuries in this case. So symptoms of themselves aren't physical injuries. So things like pain or weakness or swelling, they're not physical injuries. They could be the result of a physical injury, but not necessarily. So those sorts of things can't be covered separately. So we really want to encourage you to think about the condition you're treating and whether it truly represents this actual damage, which is what a physical injury is, and also what your natural healing timeframes might be for accidental injury. So a general rule of thumb that we use is that a physical injury caused by a sudden one-off accidental event will heal alongside a normal soft tissue healing timeframe. You normally a period of weeks rather than months or years. An example of a client with a long history of recurrent episodes of non-specific low back pain. They have an accident which coincides with an episode of back pain. Claims lodged for a lumbar sprain. So it begs the question: how long should ACC provide treatment and support for the back pain? If we think about the finite duration of a sprain injury in the context of their long history of back pain. So we've talked a bit about what an accident is. We've talked a bit about what an injury is. And now we're going to discuss causation. Now, causation is really the link between an accident and an injury. And normally if you apply clinical reasoning, the history, including the onset of symptoms, the description of event, will give you a pretty good clue as to whether that event caused an injury. But sometimes it won't make sense. There may be a random onset of symptoms, or the client may not be able to recall any event. In this scenario, it's unlikely that an event or an accident caused the presenting complaint. So it's just something to be aware of. In some cases, the client will recall an event, but it won't fit with the nature of the pathology that you're treating. So an example could be a patient with a say, confirmed carpal tunnel syndrome, relating the onset of their symptoms to a single lifting event. The two won't be causally linked. Sometimes there might be like I mentioned earlier, a claimed accident that is a series of events, so a series of events over a defined period of time. So if that's the case, then the physical injury needs to make sense with that series of events. It needs to be consistent with that. So a question would be, would wrist pain that's first noticed after 3 days learning to kite surf be a sprain, or would it be tenosynovitis? So those are the sort of questions that can come up. So we need to make sure that we're covering the right thing. So like I said earlier, we cover personal injuries caused by, in this context, mainly accidents and other qualifying events. But we need to know that we have the right diagnosis and that we're covering the right thing. That's important because we need to make good decisions about treatment, or more investigations, or more entitlements. Say a claim that's lodged for a sprain, later investigations might show that there's some more severe damage. So we need to know about that so we can provide the right supports. Alternatively, in the course of your investigations and treatments, you find out that the client's condition is no longer ACC related. Again, you'll need to make sure that you're no longer treating it under ACC and let us know. An example in that case might be you're treating a knee sprain in a person with significant end-stage osteoarthritis of the knee. At some point, the problem becomes OA. It's no longer the sprain, so we need to be updated on that. Another example could be a shoulder sprain is in fact frozen shoulder, which, as it turns out, is not caused by the event in question, such as using a hairdryer. But so it's just important that you keep us in the loop. So we've got some examples today, just to run through, and they're reasonably straightforward. This is as Kate said, this is a sort of a high-level overview of ACC in this sense, covering causation. But we'll talk a bit about these examples. Now, the first one is Gary. He was out for a run and he fell over and dislocated his left shoulder. So you've got a reasonably clear picture here of an accident. Gary fell, presumably onto the ground or a tree or a rock or whatever. This would be an external force on Gary. We've got an injury. Shoulder dislocation normally involves some sort of tissue damage. So when we're looking at what a physical injury is, that would be the shoulder dislocation. And it makes sense that fall caused the shoulder dislocation. That's your causation question there. So this one would meet criteria for ACC cover. So this next example, we've got Jenny, who had a minor car accident and went into the GP clinic for a checkover. So the GP didn't find any injury, and reassured, Jenny then went home. So in Jenny's case, we've got an accident. So I haven't given you much detail about the car accident. Maybe someone crashed into Jenny, maybe Jenny backed into a bollard, who knows. But there is an external force involved. So that in ACC terms would be an accident. It was obviously enough for her to worry about, enough to go to see a GP. So it was probably more than a simple ding. But anyway, GP examined her and found no sign of an injury. So we don't we don't have a physical injury, and if we don't have a physical injury, we can't have causation. So that's a situation. We've got an accident, but luckily there was no injury and no causation, so that wouldn't be coverable by ACC. It wouldn't need to be, because to all intents and purposes, Jenny's fine, which is good. So in this final example, this is Ruth, and she presents to you with an 8-week history of shoulder pain and stiffness after pulling out a stubborn weed. So we generally consider pulling out of a stubborn weed to be an accident. Some of those weeds are pretty stubborn, but the sudden release of the weed and sudden force, external. Even if it's a relatively minor event, it could still amount to an external force. So that would be an accident in this case. Bigger question: what is the injury? So she's got pain and stiffness in her shoulder, and you question Jenny a bit closer, and it turns out it's getting worse over the last 8 weeks, not better. Particularly the pain and the stiffness are deteriorating. Following more investigations, it actually turns out that Jenny's got frozen shoulder, or adhesive capsulitis, which wasn't actually caused by the pulling out of the reed. It's just simply when Jenny first noticed it. So in this situation, we've got an accident. We've got the weed incident. We've got a physical injury. So adhesive capsulitis and the changes in the synovium inside the joint would be a physical injury, but there's no causal link between the two. They simply coincide with each other. So that's a few examples for you to think about there. Now I'm just going to ask Ben, have we got any questions?
We do, Nigel. Thanks for that. We've got one from Eugene. Can repetitive strain at work, for example, using a keyboard too much, cause tennis elbow? And would that be covered by ACC?
Yeah, so good question. Tennis elbow isn't normally an accident-related condition. So I've talked a bit about what accidents are. In some cases, we might consider whether this is a work-related gradual process injury. We're not going to talk about individual cases today, as obviously every case is different. So we would make a decision on cover once we had all the information about the client, and that determines which criteria it might fit under.
Cool. Cheers, Nigel. One from Luke. What constitutes a new injury versus a re-aggravation of the covered injury?
Yeah, so this can be a tricky one for providers. Like we generally think a new injury means there's been new tissue damage. So when I talked about physical injury before, that's actual tissue damage. So a new injury from a new accident, consistent with the mechanism of the injury or the presenting signs and symptoms, then that's a new personal injury caused by an accident. Maybe re-aggravation would be when there's been an increase in symptoms, normally the original symptoms that the client might have seen you about, maybe following an activity, maybe even a new accident, or even sometimes with no clear cause, but with no new tissue damage. So it's simply stirred it up, so to speak. So that wouldn't necessarily be a new claim, that would be a re-aggravation.
Perfect.
Hi.
Hopefully that answers your question too, Vicky, who sent through a question. Got one from Barry as well. If my client has a sore back after a fall, but I find out while doing my assessment that they have different leg lengths, can I get them a heel raiser under their back claim?
Yeah, well, while a client may be struggling to recover from their back injury, maybe in due part to the leg length discrepancy, the treatment that you provide needs to be directly related to the covered injury. So this is in this case it's a back sprain. The underlying condition here is a leg length discrepancy, which isn't related to their back sprain, so it's not something we can help with, unfortunately.
Okay, thanks, Nigel. Those are the questions for now. Cheers.
I have a question from Kevin. What happens when Jenny when she develops neck pain the day after seeing her GP?
So if that's a physical injury. So if it's been diagnosed as a physical injury after then that could be lodged as a claim for cover. Not every episode of neck pain is actually a physical injury, so it would determine on what that diagnosis is. And you don't need to be exact, you don't need to know for sure, it just needs to make sense based on the mechanism and the signs and symptoms. But if it's not diagnosed on the day of, it doesn't mean it can't be diagnosed at a point after that. There's obviously a time limitation on some of these things, but that certainly could be looked at.
I have a question also from Judy. What medication taken by a pregnant mother for, say, epilepsy be relevant for claim once baby born and evidence of some developmental challenges?
So that would be potentially a treatment injury. So you're looking more along the lines of the treatment injury legislation, what the medication was, whether it was provided by a registered health professional, taken at the direction of a registered health professional. And you still need to determine a causal link between that medication and the condition. Now, there can be claims for what's called fetal valproate syndrome related to anti-epileptic medications. ACC looks at those sorts of claims. We do look at them. Again, can't comment on specific cases, but there's certainly claims that ACC would consider. But I do have to add with a hint of caution, we do have to apply the legislation to those sorts of claims. So the causal link can be quite a tricky one in those cases.
I have another one from Luke. Can allied health providers register a gradual process injury? And is this a different form process to standard? Like digging in the garden, sore back next morning, so no particular strain at the time. And is there a time frame for what is defined period of time for repetitive strain injury? So you might want to answer the gradual process one first. Can allied health providers lodge allied health?
Yeah, absolutely. I mean, we need to know with some degree of certainty what the injury is. So we need to understand what the damage is that you're claiming for, and how that relates to the activity in question. And I mentioned earlier about how an accident could be considered an event or a series of events over a defined period of time. Now, I think the example mentioned, Mary, was digging in the garden. No particular accident, was just a bit sore the next day. Now, how we define physical injury in that case, how we would determine what the clinician diagnosed, what the signs and symptoms were, where their clinical reasonings put them in terms of the diagnosis, whether they've simply got low back pain or have they actually got some sort of physical injury to their spine, and is that causally linked to the activity of digging. There's lots of different things can go on in someone's lumbar spine that could be aggravated by digging, or maybe there was a true physical injury caused by that. So again, it could be looked at, it could be lodged for and looked at for sure.
All right, thanks so much, Nigel. What a huge topic. Moving on now to the cost of treatment regulations versus being contracted. So depending on your profession within allied health, you can provide your services through cost of treatment regulations or apply to hold one of our contracts. So under regulations, you do have responsibilities in the way that you work with clients, and the Working Together handbook helps you to understand these. There's a link there at the bottom of that slide. If you're a hand therapist, a physiotherapist, or a podiatrist, you may be eligible to hold the Allied Health Services contract. We also have a contract for orthotists who can't operate under regulations. And there are a number of other different types of contracts that ACC offers that you may be able to work under as well, such as training for independence, VOC rehab, pain management, concussion, etc. Details on these contracts are all available on our website, and you can apply for our contracts through GETS. So looking at the difference between regulations and the Allied Health Services contract. So we'll go through the table there. Payment rate. So under regs, It's per consult or per hour. Now the per hour is calculated by the minute, and we do have a time-based billing module on that on our website that can just help make sure you're doing that properly. Under the contract, we have a flat fee for all consults. For orthotics, under regulations, you need to apply for prior approval for all. Under the contract, we do have some included which don't need prior approval. Treatment limits, so under regulations, it's 16 and then prior approval required for more. Under the contract, it's 50 treatments over the life of the claim, with a file review required prior to the 16th if the client's not under specialist care. So for clinic accreditation and the clinical director requirement, so under regulations, these are not needed. However, under the contract, they are both required. The regulations, they are for services provided under our legislation, and the government has a large part to play in pricing these services. The ACC contracts allow us to set our own prices based on what we believe are market rates. And we work with the professional bodies to understand what's happening in the sectors. So for more information on the contract, just please read the service schedule and operational guidelines, which are on our website. Okay, registering as a provider. To work with us, you'll need a provider ID. So you'll need to fill out the ACC 24 form and include your annual practicing certificate. Our registrations team will then work with you to verify your email. And it doesn't take long to do. Usually you'd get an ID number within 1 or 2 days if we have all the information that we need. We encourage all new providers to read and complete the relevant onboarding resources on our website, which have just been updated. Okay, do we have any questions, Kay?
We do, Kate, and it's quite nicely tied into some of the stuff that you've been talking about. So a question that came from Brett was, what if my client needs rehabilitation orthotics, such as a brace, or rehabilitation equipment? And I think you touched a little bit on orthotics.
Yep, I did briefly. So it does depend on how you're providing your services. So under the Allied Health contract, there are some named orthotics or equipment, including knee braces, moon boots, crutches, that you can access without requesting prior approval. For anything that's not named, you will need to send in a request using the ACC 7428 form. If you're providing your services under regulations, you'll need prior approval for all orthotics, again using the ACC 7428 form. So for any other equipment not under contract, you will need to get in touch with us to discuss the client's needs.
Perfect, thanks Kate. Question from Wusik. So Wusik registered a number of years ago as a provider. Do I need to re-register every year?
No, thank goodness. So you don't need to re-register. However, you do need to keep your APC renewed. So our registrations team check through the registrations board's current APCs against our provider IDs. And if you've let yours lapse, your provider ID will then be inactive and you won't be able to invoice us. So just make sure your APC is continually up to date.
Perfect, really good advice. And last question from Mina, who's an occupational therapist. Do I have to be a contractor with a rehabilitation company to be able to work with ACC?
It's a good question, and not always. It depends on your profession. So as an OT, you can provide treatments under regulations, and you can also hold the Allied Health contract if you're a hand therapist. And then there's also other contracts you can work under, ones that I mentioned. So an OT, you could be under TI, pain, concussion, non-acute rehab, as a few examples. And these are multidisciplinary contracts. So for those ones, you may want to go under a rehabilitation company as a subcontractor or as an employee. That's an option. But I would probably suggest having a look on our website under the health provider section, getting started. That will tell you a bit more about how you can provide your services.
Awesome. And I will flick that link into the chat for everyone if anyone's interested in having a look. I think that's all the questions for now.
Great. Thanks, Kay. Okay, moving on to lodging claims. So all claims begin with an ACC 45 form. So making sure that the information is correct before lodging will mean faster access to treatment and support for your client. So please just make sure that the diagnosis is within your scope of practice, that the patient's details are completed and correct, that there is an identifiable accident and injury, and only tick the treatment injury box if the injury was caused by a health practitioner while providing treatment. Okay, moving to Nigel.
Thanks, Kate. So yeah, so on that note, what injury do you put on the claim? Well, sometimes there's a clinical suspicion of an injury, but you might not necessarily have absolute proof of it. But if you can put the closest sprain type injury that matches that body site on the claim, if that makes sense to you and is causally linked to the accident, then that's the best fit at that point in time. You might have a clinical suspicion that there's a lateral ankle ligament rupture, but it's not yet proven at that point. In a case like that, I'd suggest just putting an ankle sprain on there until such time that we can maybe update the diagnosis if we get further evidence. We always need to remember that we need to be satisfied that the accident caused an injury, but like I said, you may not know exactly what that injury is, but the mechanism in the clinical picture still needs to be consistent with an accidental injury. And you know, I talked a bit earlier about this series of events over a defined period of time, as well as a single one-off event being an accident, and how the pathology that you're diagnosing, at least provisional diagnosis basis, has to make sense with that. Okay. Now, it's not really appropriate to lodge claims for body sites only to get imaging for it. So, for example, you're treating a client's shoulder sprain and they mention they have heel pain. It's not really appropriate to add heel contusion to the claim simply to access an ACC subsidised X-ray of the heel. Unless, of course, well, if the clinical picture in front of you makes sense that the accident that damaged their shoulder also potentially caused a heel injury. So on that basis, but yeah, you just need to look at it as it is.
Right, treatment extensions and updating diagnosis. So allied health providers, you need to get in touch with us when the treatment trigger number of 16 or 50 if you're contracted has been reached. It's been more than a year since an allied health provider treated your patient for the first time, or if you're adding or changing a diagnosis. If you're an acupuncturist, you'll need to get in touch with us if the treatment trigger of 12 has been reached, or it's been 12 weeks since the client's first treatment. There are two ways of getting these extensions. If it's a standard request, you can call us. If it's a complex request, you will need to fill out an ACC 32. So let's look at the difference between standard and complex. A request is considered standard when it's within 12 months of the injury, or if there's been surgery, it's within 12 months of the surgery date. If the injury is already covered, and it's the first request from your clinic, and it's for the original diagnosis. A request is considered complex when it's over 12 months since the first treatment, or if there's been a surgery, it's more than 12 months since the surgery date. It's not your first request, or if you're contracted and you've reached the 50 treatments. It's for hand splinting over 308.89. The request includes acupuncture, or if it's for changing or adding a diagnosis. So for complex, you'll need to supply clinical information. We will consider each request on a case-by-case basis, and we'll tell you if we've approved or declined your request. Now, there's a lot of information there, and it can be a bit confusing, but please use that link on the bottom there to go onto our website for more information on which way to submit, and it's also got the read code list there as well. clinical records. Over to you, Nigel.
Thanks, Kate. So, yeah, it's really important that you keep good clinical records. So they're really important for both you and for your clients and for ACC. It's important for us to know what treatment is being provided, for what conditions. Should a question ever arise over a cover or causation, there needs to be evidence of informed consent to lodge the claim and to provide treatment. The notes need to show that the accident, the physical injury, and the causal link have been considered, at least on a basic level. You know, there needs to be some evidence of clinical reasoning. It's important also that we know what impact the injuries had on the client, if we ever need to look into a high level of care or further supports they may need from us. So that's all really good stuff to have documented. We also need to know things about the progress, the clinical progress while the client's being treated. So, mentioning things such as the treatment was tolerated well is not really telling us much about what benefit the client's getting from the treatment that's being provided. Because it's in the client's best interest that they're getting better due to the treatment that they're getting. It's also good to be specific in the notes about what treatment you're doing. So if you're unable to treat someone one day, someone can step in and replicate the treatment if they read your notes. Being specific is really important. Specific in terms of the plan or the outcomes, the objectives, those sorts of things. Just saying something like review in 1 week, it's not really an adequate plan. So we just need to know, or at least have you guys thinking about, well, what's the plan for this person? What's the treatment going to achieve? Describe what you're going to do next and your rationale for that. It's really it's good clinical practice, ensuring that your notes show that the treatment you're providing is having a positive treatment effect for the covered injury. Sometimes we may ask for your clinical notes to help us make cover decisions or decisions on requests for additional services like surgery or pain management or weekly compensation, that sort of thing. Sometimes we might also request your clinical notes to make sure the treatment being provided is necessary and appropriate. And we do have a relatively sophisticated system for overseeing these treatment patterns. Anomalies in those patterns could result in being audited, things like high consultation numbers per day or high hours invoiced per day or consecutive days of treatments per client or potentially even treating family members or colleagues. So all these things could trigger an audit. So it's just, aside from, being careful in that regard, just having good clinical notes is really important. I'll just hand over to Kate for this one.
Yeah, thanks, Nigel. So, which leads quite nicely into our position statements. So we've developed these to align with professional standards and ethics and our legislation. So position statements guide you and explain what we need you to consider in specific circumstances. So it's really important that you take time to read through them, as you'll need to document your actions and rationale in your notes. So the positions include treatment of family, treatment of colleagues, treatment by allied health students, treating in a sports setting, and same-day allied health treatment. Now, any questions?
We'll hear for you, Kate. One from Ricardus. Regarding ACC 32s, what types of information or supporting documents will I need to send through with my application?
Great, everything and anything that you've got. So the more information means the better decision that we can make. So your treatment notes, outcome measures, treatment plan, any imaging reports that you may have, send it in.
Perfect, and I'll pop a link into the chat now, which shows where you can go to for your 32 requests. And
thanks, Ben.
We've got one here from Lay. How long does it normally take from when we lodge a claim electronically to the claim being accepted?
Okay, so it depends on the complexity of the claim. So for our simple ones, it can be in a couple of minutes. Obviously, our complex ones will be, when we need more information, will be longer than that. We do keep stats on this and on our website. Looking at last year's, I think it was just under 2 million claims that we accepted, and 64% within 1 to 2 minutes were accepted, and I think it was 81% were accepted within 24 hours. Then for our complex ones, which make up about 2% of accepted claims, they're up to about 70 days. So it's a pretty big difference there, depending on what information, further information we may need.
Awesome, cheers, Kate. That's all for now. Anyone else?
Good.
Pass back to you guys. Cheers.
Cheers, Ben. Okay, we've got next, digital services. So signing up to our digital services will make things faster and easier. It'll help you to lodge claims, look up claims information, send invoices, and check on your payments. And using our digital services, it means using either a practice management system or our e-business gateway. So a practice management system that works with us directly with us for claim lodgement, treatment requests, and invoicing. If you don't have a PMS, you can then contact our e-business team for help with using our gateway. For both of these options, you will need to be registered as a provider or vendor and have a digital certificate. These certificates are issued by HealthLink and they're renewed annually, with ACC covering the cost of this. And you may already have one for your Ministry of Health work, in which case you can use it with us too. Just a quick reminder about invoicing is that you must submit your invoice within 12 months of treatment, as late invoices will likely get declined. And also we let the vendors know of any pricing or code changes. So it's really important to read a correspondence from us. If you invoice us with incorrect codes or incorrect amounts, they will be declined and you'd have to resubmit them, which is obviously not ideal. Okay, resources. So we have some great resources to help improve your knowledge and to support the onboarding of any new staff. These include online learning modules, quick guides, introductory videos, and webinars like this one tailored directly to providers. So the upcoming ones are, we've got to meet the team, cultural competency, mental injury, and ICC. So you can keep an eye out on our website for these and our provider updates. Right, so we've completed the bulk of the presentation. So we have a bit of time now for any final questions.
Thanks, Kate. And we have got a couple which were related to the digital services and resources section. So Shushin has asked, how often can I invoice ACC?
Well, I mean, our preference would be as soon as you can after providing the service. So we'd definitely expect it within 2 months. Obviously, as I mentioned, 12 months after that, you would likely get declined. But yep, doing it as soon as possible is our preference.
Thank you. And one from Helen, and this is a great question, Helen. How do I link my PMS to Provider Hub?
Yep, great. So some of you may have heard of Provider Hub. So that's a new system that ACC is developing for a smoother interface between providers and ACC. It's still under development, but it will be taken over from the gateway. So it won't be interacting, a PMS system, you won't need to worry about it if you're working under practice management system. But if you're on a gateway, when we are ready to onboard you onto Provider Hub, you'll be contacted and we'll help you through the registration and the use of Provider Hub.
Great, thanks, Kate.
And we do have a, it is on our website. I'm wondering if Kate, we might be able to put the link in. That we've got a digital.
We can do that. Yeah, there's some really great stuff in there that will keep everyone informed of when things are starting to roll out for that as well.
Yeah, that's good. And there's a digital support team contact details there too if you want to know more information.
Great. I do have a couple more questions, which are just kind of from the general themes that we're seeing in the chats. So we've had quite a few people asking for more information about maternal birth injuries and what sort of people are involved in offering those services. What do you suggest these people do?
Yeah, that's great. So that's something really exciting for us, that from the 1st of October, we're covering specific maternal birth injuries. So I'm going to point you to the website again. We've got a dedicated page for that. And it's got FAQs, it's got some webinar dates, fact sheets, and also what to do if you're interested in providing this service. So is there another link we could put in there?
Absolutely, I'm going to be flooding the chat with links in a second.
Yeah,
and I guess just the other theme that we've seen is people asking about the other types of contracts. So Kate, I think you mentioned earlier about training for independence. Any chance that you can just explain a little bit more about what some of the other types of providers are that can offer services under contracts?
Yeah, definitely. So training for independence, as its name suggests, it's about trying to get clients sort of maintaining or restoring their independence, maximising their participation in activities of daily living in their community. There's 5 contracts under that, and the types of providers, well, it's multidisciplinary. So, and we want those programs to be quite individualised to the client's needs, but we utilise psychologists, social workers, speech language therapists, counsellors, nurses, OTs, physios, quite a range. So again, it's worth having a look at the schedule and operational guidelines on our website to see if that's a service you might be interested in working for.
Fabulous, thanks Kate. And just a special shout out to everyone for attending. We've got very busy chat rooms going on at the moment, so please bear with us while we try and respond as quickly as we can. If we don't get to your question and you really want us to get back to you, I think coming up is some of the contact details for the team as well. So feel free to fire them through. Thanks Kate, back to you.
Great, thank you Kay. Okay. Right, so as Kay mentioned, we're here to help. So please get in touch with us. I won't go through these, but here are a few helpful contact details for you. What's next? So please do just take a minute after this webinar to let us know your thoughts. We're particularly interested in what you thought about the format of this webinar, what you liked about it, and how it could be improved for future. Please also let us know if there are any other topics that you'd be interested in hearing more about. Just simply click the link in the chat, another link, and share your feedback with us. So again, I just wanted to say a really big thank you for giving us your time today. We do really appreciate that. And now I will finish with the karakia. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha, mo te oranga tangata, kia puta ki te whae au, ki te ao marama, home e, hui e, tai ki e. Thank you very much.
Thanks, everyone.
Thanks.